Quem somos? O que buscamos? A DIN1 apresenta o núcleo técnico operacional do maior centro de diagnóstico em genômica da América Latina. Somos especializados em exames genéticos de alta complexidade e medicina personalizada. Oferecemos o melhor da medicina diagnóstica para nossos pacientes e contamos com uma equipe de especialistas em genômica, biologia molecular e bioinformática. Temos à nossa disposição o que há de mais inovador para aumentar a efetividade do tratamento e qualidade de vida dos pacientes. Contamos com equipamentos de amplificação e sequenciamento de última geração e metodologia de análise avançada. O nosso compromisso é trazer um diagnóstico de precisão com excelência. Trabalhamos juntos para entregar sempre o melhor resultado, porque aqui cada paciente é único. Você é a nossa razão de existir.
Olá a todos, uma boa noite. Aqui quem fala é Cristovam Scapulatempo Neto. Eu sou médico patologista e diretor médico da patologia da ASA, responsável pela patologia molecular também da DIN1. É um prazer ter todos vocês aqui conosco essa noite, por mais um webinar DIN1. Hoje a gente vai ter uma palestra muito interessante sobre o Signatera, que para mim é o teste que vai mudar a maneira de como fazemos oncologia em muito pouco tempo. Tá? A gente já está autorizado na prática para algumas doenças, mas a gente vê que o racional é extremamente interessante, né? É só a gente pensar como foi a revolução do tratamento da leucemia mieloide crônica, uma vez que você tinha um biomarcador disponível e que você poderia seguir a doença, acompanhar a resposta com esse biomarcador, que na verdade era BCR-ABL, e a gente foi aumentando a sensibilidade dos métodos de detecção até chegar no PCR, no PCR digital, e quando soma essas cópias, a gente fala que teve uma resposta molecular completa, ou seja, esse paciente ele vai muito bem, obrigado. Então, a gente tem hoje o prazer aqui de ter o Dr. Angel Rodrigues, que é médico oncologista e diretor médico de oncologia da Natera. Ele vai ser o nosso speaker de hoje, ele vai falar sobre os highlights da ASCO, né, os trabalhos que foram apresentados e quão interessante é a metodologia e os resultados foram. Dr. Angel?
Ready? Okay.
I think you can start. Okay.
Okay. Let's see. Let me share here. Okay, you can see my screen?
Yes.
Okay. Well, again, thank you, everybody. Thank you to the organizers for inviting me to share our data and recent presentation from ASCO 2020, which occurred about 1 month ago. Today, I will provide some insight into real-time molecular monitoring with Signatera in the care of patients with cancer. My name is Angel Rodriguez, and I'm a medical oncologist and medical director at Natera.
Angel, do you believe that's a good idea to show now the introductory video regarding the methodology, or you are going to explain in the presentation now? How does Signatera works?
I guess you can. You want me to stop here and you can show it?
Okay, let's do it.
Okay.
Okay.
And I'll go ahead. And we'll go ahead and show a video about how Natera works. Go, Signatera, go.
After surgery or chemotherapy, how do we know if there is any cancer left in the body? Currently, clinicians rely on imaging and blood tests to look for signs of remaining cancer or recurrence of cancer. The DNA that cancer cells release into the blood is called circulating tumor DNA, or ctDNA, and is typically present at very low levels. But are imaging and conventional blood tests sensitive enough to detect molecular traces of cancer in the body? Signatera is a new blood test that can identify molecular residual disease or recurrent cancer sooner than existing methods by detecting the presence of ctDNA. Signatera is a personalized tumor-informed test optimized to detect ctDNA with high sensitivity and specificity. First, whole exome DNA sequencing between the tumor tissue and normal cells are compared to identify mutations unique to the patient's tumor. Next, for each patient, a Signatera test is created to track the top clonal mutations, similar to a unique tumor signature. This personalized tumor-informed test can then be used to detect, measure, and track extremely low concentrations of ctDNA in the blood during treatment and remission. Physicians can use Signatera to support more informed treatment decisions by determining risk of recurrence, detecting early recurrence, and assessing changes in ctDNA levels in response to therapy. A positive Signatera result means that ctDNA is detected in the blood, and there's a higher risk of cancer returning without further treatment. A negative Signatera result means that ctDNA was not detected in the blood, and data shows the risk of cancer recurrence is greatly reduced. Serial negative Signatera results further confirm decreased risk of recurrence. Revolutionizing cancer care begins with revolutionary testing. Learn more at nateraoncology.com.
All right, well, thank you. So in today's webinar, I will offer an overview of Signatera and review 4 abstracts that were presented at this year's ASCO virtual meeting. 2 of these abstracts were in colorectal cancer, validating our most recent data. And one of them is the real world use of Signatera and the rates or chances of having ctDNA detected in early stage colorectal cancer. The second one is risk stratifying patients and looking at outcome of patients who had ctDNA detected. Third one is Signatera analysis in patients with advanced hepatocellular carcinoma. And a fourth one, the importance of filtering CHIP mutations or clonal hematopoiesis of indeterminate potential mutations in ctDNA analysis. First, an overview. Natera is a company that, although relatively new to the oncology field, it has been a leader in cell-free DNA technology for many years. We have now performed over 2 million clinical cell-free DNA tests worldwide. And Natera has offerings in reproductive health with the Panorama, which is a test for non-invasive prenatal testing to detect fetal-derived ctDNA, and in organ transplant health with Prospera, which is a test to identify early kidney transplant rejection by detecting donor-derived ctDNA. Now in oncology, we offer Signatera. All 3 of these tests leverage the same core technology, combining novel and unique methods of multiplex PCR along with our proprietary and bioinformatics models for detection and characterizing the signal of ctDNA that we are looking for. This technology is described and protected in over 80 patents and over 50 peer-reviewed publications. It's important to note that there is a spectrum in the use and applications of ctDNA testing in oncology. On the left side is the potential to use ctDNA to screen asymptomatic healthy individuals in the goal of early detection and maybe complement our existing screening modalities like mammography or colonoscopy. On the right side is the current use of ctDNA that you may be familiar with, which is liquid biopsy in the metastatic setting. Typically, the tumor burden here is high, and these liquid biopsies allow us to detect mutations that have been linked to either treatment therapy or treatment resistance, therapy benefit or treatment resistance. Shifting to the middle of the slide, identification and measurement of molecular residual disease is where Signatera's strength lies and where we have focused our clinical research. presence of MRD by Signatera after best standard treatment can identify a population of patients that are destined to relapse. You can think about it like leukemia and testing for molecular markers in leukemia as surveillance. Signatera can also be used as a surveillance tool monitoring longitudinally, where serial testing can identify recurrences much earlier than our current standard of care like CT scans or biomarkers. Identification of patients with molecular recurrence can allow us to manage these patients with either intense imaging surveillance program, which could lead to detection of oligometastatic disease that could potentially still be curable, or at least identification of patients that could benefit from enrollment into clinical trials. Finally, the third area where we focus Signatera is treatment response monitoring and early prediction of benefit. I'll show you how dynamic changes of ctDNA correlate with treatment benefit and can change the landscape of how we design clinical trials. But first, in order to understand Signatera, I'll tell you about the approach. Basically, we take a sample of a patient's tumor as well as a patient's blood sample. This approach differentiates Signatera from other liquid biopsy tests because that are tumor naive or tumor non-informed, and other biopsies, other blood tests do not take into account the genetic information of the tumor. Knowing the patient's tumor-specific mutations allow us to dive deeper in the circulating cell-free DNA to find that single molecule of ctDNA in the blood. The first part of the test process involves performing whole exome sequencing on the tumor tissue and match normal DNA of the patient. And based on these results, we can identify the differences and create a molecular signature of the tumor mutations. We then look at the somatic tumor-derived mutations and apply our proprietary algorithm to select the most clonal, most important single nucleotide variant or mutations that are, again, unique to that patient's tumor. And we design and manufacture an assay for that patient, which is 16-plex PCR. We sometimes get asked why 16 genes, and we have reached maximum sensitivity and specificity of our tumor test by tracking more than one gene. And tracking too many genes can sometimes affect the specificity of our test. But our current assay is able to detect at 99.8% specificity when there is as little as one tumor molecule of DNA in roughly 10 milliliters of blood, or 10,000 background cell-free DNA molecules. In addition to that, the type of genes that we track is also important. It's not just about the number, but the quality of the genes. Most of these genes are what we call clonal and passenger in nature, and therefore they do not succumb to selective treatment pressure and therefore be lost over time. Interestingly, we report our results as mean tumor molecules per milliliters as opposed to variant allele frequency like many other tests. And this allows us to quantify the tumor burden more accurately. Signatera's clinical performance has been validated in several tumor types. Shown here are the results of Signatera's prognostic performance in 4 of our publications in colorectal cancer, breast cancer, lung cancer, and bladder cancer. Patients represented in these 4 Kaplan-Meier curves completed curative intent treatment, and essentially, if patients test positive for Signatera with enough follow-up, these patients' cancers almost always recur. If a patient tests negative and remains negative with serial testing, only very few of those patients' cancer will ever recur. And these studies demonstrate that Signatera can identify micrometastatic disease in patients that will experience disease recurrence. So now I will move forward to talk about the 4 presentations that were in ASCO 2020. And the first abstract, which was presented by Dr. Kazi from the University of Iowa, asks the question, what is the molecular residual disease detection rate in early stage colorectal cancer patients? In this study, 535 unique patients with either stage 1, 2, 3, or 4 colorectal cancer who underwent ctDNA testing as part of an early adopter program were analyzed. 715 samples were collected. 57% of the patients were male. Most of these patients had colon cancer, followed by rectal cancer, and then other cancers such as appendiceal cancer. And this study evaluated the relationship between ctDNA status and including outcomes, including radiologic imaging and multivariable analysis was performed with all these variables. As you can see here, post-surgical ctDNA detection was significantly associated with the stage of disease, with 7 out of 68 patients, or about 10% of patients with stage 2 disease, had detection of molecular residual disease, whereas 27% of patients with stage 3 disease had molecular residual disease detection. Signatera MRD positive rates approximated expected relapse rates in patients with T3 stage 2 disease, which was 6%. And also, it expected the relapse rates in T4 disease with 29% of the patients testing positive. Patients with low risk stage 3 had a MRD rate of 9.3%, and high risk stage 3 had a 40% ctDNA detection. Multivariate analysis revealed that T4 status, or more aggressive disease seen histologically versus stage T1 through 3, was the only statistically significant covariate associated with ctDNA positivity. In the setting of metastatic disease, the Signatera assay was able to detect circulating tumor DNA in all 16 patients who had active metastatic disease without treatment or with treatment that was no longer working. In patients where there was documented stable disease or partial response, 9 of 15 patients had detectable ctDNA, showing that ctDNA could clear with treatment. And in a setting where patients had no evidence of disease, MRD was detected in 4 of 12 patients, suggested that these patients indeed had active disease and probably higher risk of recurrence. Close follow-up with surveillance and monitoring the trend in ctDNA would be helpful in monitoring this disease with MRD positivity. So Signatera can be helpful in determining treatment benefit or resistance, especially in those patients who do not have currently detectable, reliable tumor markers. In patients who had oligometastatic disease, ctDNA was detected in all patients prior to surgery, whereas 26 of 53, or 50% of the time after surgery, ctDNA was still detected, suggesting that this could identify patients who would ultimately have a better post-surgical outcome than those who had ctDNA positive disease. And if patients were on treatment, then 1/3 of the patients had ctDNA detection. However, more studies are needed to determine if patients who undergo treatment of rare cancer, oligometastatic disease, benefit from chemotherapy or not. And these data will be presented in an ESMO. Important to note that the timing of when ctDNA is drawn is important. After surgery can induce a reactive cell-free DNA, background cell-free DNA levels. And those background cell-free DNA levels can impact the ctDNA detection. Waiting for at least 3 to 4 weeks for clearance of that can help detect MRD. So 2 to 4 weeks after treatment is when MRD are most reliable, and within 2 weeks is an unreliable time point of drawing blood after surgery. So MRD rates across early stage and oligometastatic patients reflected expected relapse rates and demonstrated treatment response dynamics in clinically useful way. Our second presentation, presented by Dr. Noelia Tarazona of the Encliva Instituto de Investigación Sanitaria in Valencia, Spain, is basically an expansion of previously published work with colorectal data set to further validate the use of ctDNA assay to detect MRD in colorectal cancer patients. In this study, 198 patients were enrolled. This was a prospective study that was analyzed retrospectively with banked blood samples. 193 cases were analyzed with a median follow-up of approximately 2 years, ranging from 1 month to 42 months. Most cases had stage 3 disease, followed by stage 2 disease. And all patients had baseline Signatera performed 1 month after surgery, and then every 3 months thereafter, for a total of about 1,052 total plasma samples that were collected and analyzed. As you can see here, Signatera performed exceptionally well in this study. ctDNA positive 30 days post-operative setting as a single time point was able to predict an increased risk of recurrence, with 78.5% of patients who tested positive had relapse of their disease, and only 9.2% of the patients who tested negative had relapse of their disease, indicative of a hazard ratio of 14. In the middle Kaplan-Meier curve illustrating patients who were tested after completion of adjuvant chemotherapy, curative intent treatment, the hazard ratio was 27.9. Post-adjuvant MRD positivity is indicative of a treatment-resistant disease and identifies patients in need of better than current standard of care treatments. These results highlight the importance of incorporating MRD positivity as an eligibility criteria into novel clinical trial design, and also into identification of patients most likely to relapse who could potentially have salvaged curative intent treatment when found to have oligometastatic disease. And then the third Kaplan-Meier curve on the right includes patients who also did not undergo chemotherapy because of clinician or patient discretion. And the hazard ratio was about 47.5. So these results do show that positive Signatera result is indicative of micrometastatic disease that is destined to relapse with enough follow-up. The median lead time over radiographic evidence in this study was 8 months, ranging from 16 days to 16 months. It is important to note that because this was a retrospective study, that lead time may be slightly higher than real life. For example, if a patient would have in the clinic a positive ctDNA test, that may prompt the clinician to order imaging at that time or sooner, maybe 3 months later, and that recurrence might be detected earlier than 8 months. But in this study, retrospective analysis, it was proven to be 8 months. Multivariable analysis with traditional risk factors that are currently used in the clinic revealed that longitudinal ctDNA status was the only significant risk factor for recurrence of disease. So currently there are several prognostic risk factors that are considered in the clinic when the oncologist is trying to decide whether to give or not give chemotherapy, and these factors are shown. In the most potentially clinically impactful scenario would be in patients that have stage 2 disease with high risk features where the risk of recurrence is difficult to assess before determining the benefit of chemotherapy. And, a positive ctDNA status may influence the decision to recommend a chemotherapy or not. Shifting gears to a different kind of cancer, our third poster had to do with hepatocellular carcinoma. In this study, the investigators sought to explore the clinical trials application of Signatera monitoring in patients with advanced hepatocellular carcinoma treated with immunotherapy, longitudinal and personalized detection of ctDNA for monitoring the treatment response to atezolizumab and bevacizumab, which is now a first-line preferred line treatment, was evaluated. Baseline and post-treatment ctDNA levels were analyzed in relation to treatment response. Patients were classified into subgroups before Kaplan-Meier curve analysis. Baseline samples prior to treatment were collected. ctDNA high versus low was defined relative to the median. ctDNA absence or presence was determined after 1 cycle and also after 3 cycles of treatment. And response was assessed by IRF RECIST criteria. Again, this was an exploratory analysis of a retrospective exploratory analysis of a prospective study. So the subset analysis included 48 patients of arm A of the phase 1b portion of the study, of 104 patients treated with atezolizumab and bevacizumab. 10 patients who had complete responses were analyzed, as well as 11 patients with partial response, 12 with stable disease, and 15 with progressive disease. Signatera assay was successfully designed in 47 of the 48 patients, and detection of ctDNA was seen in 96 or 45 of the patients with unresectable hepatocellular carcinoma, with a median mean variant allele frequency of 1.8 or 70 mean tumor molecules per milliliter. ctDNA levels did correlate with tumor burden, with lower levels in patients with lower tumor burden and higher levels in patients with higher tumor burden. And in the cohorts of patients with the different responses, where there was seen higher levels in patients that ultimately had progression of disease. Most responders who had complete response or partial response had decreased or non-detectable ctDNA levels at cycle 4, day 1. And ctDNA levels in nearly all non-responders either increased post-treatment or remained above detectable levels. Progression-free survival was significantly better in those patients who tested below the median as compared to those who tested above the median when looking at either results of Signatera drawn at the beginning of cycle 2 or the beginning of cycle 4. So rapid identification of patients who did not benefit from treatment was achieved by higher ctDNA levels after 2 doses of ctDNA of immunotherapy. From as early as cycle 2, day 1, patients with lower post-treatment ctDNA levels appeared to be associated with longer progression-free survival. And longer progression-free survival and overall survival was observed in patients whose ctDNA level changed from present to cleared to negative after a couple of doses of treatment. So overall, our results illustrate the promise of ctDNA as an emerging biomarker for patients with HCC that may potentially help in monitoring treatment, but also in future clinical trial design to use ctDNA clearance or reduction as a marker for predicting treatment benefit. Our last study it analyzes CHIP mutations that occurs in patients that we analyzed in our with our assay. So as you all know, clonal hematopoiesis of indeterminate potential is an age-related phenomena where somatic mutations accumulate in the cells, in the white blood cells or in the bone marrow. Cell-free DNA of CHIP mutations are indistinguishable from cell-free DNA of tumor-derived mutations. And CHIP mutations are by far the most common source of false positive calls in ctDNA analysis. So with our tumor-informed approach, we are able to filter out CHIP mutations that we know are from white blood cells and therefore are not reported with our assay. So in the study, CHIP mutations were not observed in patients younger than 20, but they did increase in frequency with every decade or life thereafter. to up to 30% in patients greater than 60 or 70 years old. The most common CHIP mutation identified was DNMT3A, which is a common mutation described. And the second most common mutation was TP53, which again can be confused with as a false positive in ctDNA analysis. Among patients who had undergone treatment prior to sample collection, CHIP mutation incidence was lowest in patients with targeted therapy compared to those with prior exposure to either chemotherapy, chemoradiation, or immunotherapy. And CHIP causes false positives in ctDNA analysis and is present in up to 20% of individuals. The Signatera assay, again, filters for that. And so with that, I conclude my talk, and I can take any questions.
Very good presentation. So we have a question here from Natalia Munoz. She said that the first question is, in metastatic colorectal carcinoma setting, is often here that the tumor material used for the exome study and identification of the tumor unique signature is done by primary tumor material. Why using primary tumor material and not metastatic tissue that could have gained new mutations?
So we absolutely can do our assay in metastatic tissue, and in patients who do have stage 4 disease, we actually do prefer the metastatic tissue to be analyzed. But of course, in patients who have stage 2 or stage 3 disease, there is no choice. It has to be the primary tumor that is analyzed to be able to detect molecular recurrence.
So the one important point here is that the 16 mutations, chosen mutations, are mainly truncal mutations. So there are mutations that is present since the beginning of the carcinogenesis of that tumor. So it's a molecular identity. This test is not designed for diagnosis of resistance, something like this. It's just a monitoring test, you know?
Correct. It's a monitoring test, and this is not to be confused with other assays that are looking for actionable or targetable mutations or resistant mutations. This is more of a lifelong tumor marker for a patient.
So second question, for a patient that have extensive chemotherapy, is there a risk of not getting enough tumor tissue to do the first characterization of the tumor signature? Is it worth getting a biopsy prior to treatment?
Sure. For patients who are undergoing, let's say, neoadjuvant chemotherapy, yes, that risk does exist. If there is enough active residual cancer in the treated tumor, we can still design our assay, but it can also be designed using the biopsy prior to treatment, such as rectal cancer, breast cancer. It can be designed to those, but of course, when there's very little residual disease, it is challenging to design the assay. Correct.
And the third question is, for colorectal patients scheduled for surgery, is there any advantage in taking a blood sample prior to surgery to have a ctDNA positive read, to then compare it to after surgery and confirm that ctDNA load has decreased and have a reference of positivity in the future?
So that is a great question. And as you know, most of us medical oncologists do tend to see the patients when their tumor has already been excised, but in centers, cancer centers that have a good multidisciplinary approach where oncologists are potentially involved from the beginning, or the surgeons are actively involved, it would be worthwhile to analyze that data. And we certainly would be expect, you know, to find higher ctDNA rates prior to that. But that is certainly something that we would want to look into. Yes.
Sorry, it was muted. So let's think in two situations, okay? The first one is stage 2 colorectal cancer, you know, that we are going to use the test just to indicate or not adjuvant chemotherapy, maybe, okay? And the second scenario is when, for example, we have oligometastatic in the liver, colorectal cancer, for example, and you're going to perform the liver metastasis resections. So in the first case, I believe that it's not really important to have the basal ctDNA of this patient, because it's just to make a decision of treat or not to treat, something like this, because we don't have a very good armamentarium to make this decision, you know. So this test is the gold standard for this, I believe. But the second point, maybe it should be really important just to see if the patient could have or not any hidden metastasis, not only those that was resected, you know. What do you think about that?
Correct. I'll try to answer both. In terms of the first one with stage 2, we have to admit that although our test, the Signatera, is quite accurate as a prognostic marker and appears to be significantly better than our existing markers, the question of whether it can identify patients who will benefit from chemotherapy is a question of current clinical trials. You know, nevertheless, we do extrapolate the higher risk stage 2 with higher risk features that we are currently sometimes make decisions to treat based on high risk feature. That's where, you know, this test may help sway a physician to recommend chemotherapy. The second question is of course also very challenging. The treatment of metastatic disease in terms of do patients benefit from chemotherapy or not is a very controversial question of whether we should be offering these patients chemotherapy or not. You know, right now there is no standard recommendation. We will be presenting data in ESMO that will look at the outcome of patients with oligometastatic disease after resection and what their outcome is like with and without chemotherapy. And it's you know, now granted, in ASCO GI this year, data analyzed by JCOG did reveal that chemotherapy did reduce risk of recurrence, but paradoxically, it actually worsened survival. So patients who received chemotherapy after oligometastatic disease, actually their survival was worse. So this is a very sort of controversial question that is hard to know right now what the best approach is. But
okay.
Using ctDNA will allow us to better understand the natural history of these patients' disease.
Great. So the last question that Natalia did is Signatera equally efficient on MSS and MSI colorectal cancer patients?
It's a great question. We did do a clinical study that it is published, that it is presented as an abstract in ESMO last year. It was done in collaboration with Princess Margaret Cancer Center. And these were about 100 patients with any solid tumors that were treated with single agent immunotherapy. Some of those patients had MSI status performed. And in that study, what we did was looking at ctDNA changes after immunotherapy to predict benefit or not. and ctDNA changes was able to predict benefit and or resistance regardless of MSI status. So yeah, I think that, let me look at the question again. I think that answers the question. But ctDNA cannot replace what MSI instability or stability are testing for.
Okay, because most of the oncologists use this test to decide or not in stage 2 to do chemotherapy or not. No? So another question is, in metastatic colorectal cancer, is there any data in terms of the performance of Signatera for detecting lung metastasis compared to peritoneal disease, liver disease, or brain mets? Is there any indication that different anatomical locations may lead to different burden of ctDNA?
Sure. So the data that we have generated in all these studies do include peritoneal disease, liver disease, and lung metastasis, and that is what ctDNA detection can predict recurrence of any of those. It cannot predict where exactly it will recur, but it can predict any of those. However, when it comes to brain metastasis, it does not perform very well at predicting brain metastasis. I think it alludes to the potential, the blood-brain barrier that, maybe ctDNA either levels are either just not detected in the systemic circulation, or just doesn't enter that space.
Great. So we still have 15 minutes, I believe. So I believe that we have a lot of things to talk about Signatera. So as a very excellent tool for monitoring, for example, triple negative breast cancer, that we don't have a good blood-based biomarker to follow this patient. Can you tell a little bit about that? How
Yes.
the results in breast
Yes,
cancer?
of course. So when it comes to the potential of ctDNA and Signatera in breast cancer, not just triple negative, there is the use in the neoadjuvant setting. So this is patients that are getting neoadjuvant chemotherapy, and at baseline, one can detect ctDNA in upwards 90%, more than 90% of triple negative or HER2 positive early stage disease. So it can become a quite accurate marker for assessing response. This was data that was also presented in the San Antonio Breast Cancer Conference last year, and a analysis that was performed within the I-SPY 2 consortium. And in addition, there's data that after neoadjuvant chemotherapy, it can be, if there is ctDNA presence, it can predict recurrence. So ctDNA positivity after curative intent treatment can also increase the risk of, it increases the risk of recurrence. And it can further stratify patients who do not have a pathological complete response. So these days, patients with triple negative breast cancer get chemotherapy, they get surgery. If they do not get a pathological complete response, we generally expect about 50 to 60% of the patients to have recurrence. And ctDNA can further stratify and reduce the risk of, and so in that particular study, it showed that patients who did not have a pathological complete response, ctDNA clearance in those patients was, the prognosis was just as good as a pathological complete response. The other scenario is also in, of course, monitoring and recurrence. Now, granted, in 2020, the standard guidelines to monitor patients with breast cancer after curative intent treatment is clinical assessment, clinical exams, clinic visits, but it is not to do CT scans, it is not to do biomarkers. And currently there are studies in design to see if now with better treatment technologies, whether it be local with radiation or systemic therapies, and now with ctDNA, could surveillance of patients with breast cancer be improved? And can outcome be improved with with the use of ctDNA technology in the surveillance setting? So those are areas that are currently actively being investigated with Signatera.
Okay.
And then finally, in the assessment in the metastatic setting, trying to have an early a marker for treatment benefit rather than waiting for multiple scans and progression-free survival and overall survival. Can one predict treatment benefit just based after 2 to 3 doses of treatment with ctDNA and looking at the changes?
John, does Signatera has any study running that is comparing for the molecular signature like EndoPredict or Oncotype, something like this, and Signatera as who will be better to indicate or not adjuvant chemotherapy for breast cancer patients?
Sure. So good question. And the answer right now is that no, we do not have any comparative assessments other than to know that we do know that ctDNA levels are detected in higher risk patients, meaning triple negative, HER2 positive. I think that was a great question for investigation, but we cannot use ctDNA status and Signatera positivity to supersede the currently existing test that we use to try and predict chemotherapy benefit. But it would be interesting to see if even these days, patients that have luminal B, high risk estrogen receptor positive breast cancer, still 60% of those patients don't have relapse without chemotherapy. So could we further stratify and identify those patients that actually do need the chemotherapy is a question to be determined for the future. And it would be it'd be great for our patients if we can actually further, but no, we do not have any current data to say that we can accurately and safely identify who that is.
Wonderful. This will be wonderful, this study. So there's another study that I love it, and I always talk about this in hospitals or health insurance companies, was the results from invasive bladder cancer. So those results that show that we know that we have almost 20% of negative cystoprostatectomies or cystectomies, and when you do a good transurethral resection and do an adjuvant chemotherapy and the Signatera is negative, so maybe we don't need to do surgery on those patients. And how morbid are these surgeries? So this is a really, really great field to put in practice to use the test. What can we tell us about it?
Yeah, no, absolutely. I think you are addressing the big important issue of either de-escalation of treatment, right? We've talked a lot about escalating treatment in patients that are MRD positive because there's such high risk of recurrence. What we do have to be careful with implementing this too soon when we want to de-escalate treatment. I understand that, and granted, we are already doing that in the clinic in many patients who refuse, for example, surgery for rectal cancer after they've received neoadjuvant treatment and of course, with, as you said, the morbidity that happens with these surgeries. But we do have to be careful with extrapolating a negative Signatera result to ultimately absolutely get rid of a potentially curative intent surgery. What we can say is that a positive Signatera test is essentially associated with a 100 risk of recurrence, but a negative ctDNA test can eventually turn positive in approximately 12% of the time. So whether we can forego or delay that invasive surgery until the Signatera test turns positive is a question to be answered, and for potentially for the future.
Great, great. So I just can you tell us what we need to send for Natera for the Signatera first test?
Sure.
What the material that you need?
Sure. So our the material that we need is very similar to the material that you need for the testing that where you do next generation sequencing to do a genomic profile, which is approximately 10 to 12 slides that have at least 30% tumor cellularity in it, or of course a paraffin block with tumor tissue in it as well. We ultimately need about 20 nanograms of cell-free DNA to be able to perform the analysis of tissue, and then 2 5-milliliter tubes at baseline, and then every time you're doing subsequent testing. The turnaround time of when you get results when you do the first test with sending the tumor tissue, that can take up to 3 weeks or sometimes 4 weeks. It depends when we obtain the tissue to perform whole exome sequencing and then analyze our data. So it can take up to 3 weeks or 4 weeks to get results for that first ctDNA time point. Once we have the assay, the Signatera assay designed, it only takes about 7 to 10 days to get subsequent results of ctDNA status and future blood draws.
Great. Please, people, let's make questions. We have some minutes to talk to Dr. Angel. So
I could maybe mention about the several clinical studies that are ongoing with the use of ctDNA as a key component.
Yes, I believe it's really, really important, because the biggest question of all the oncologists that I visit and talk about the test is, okay, so I know that I have 98% of chance of recurrence if the test is positive, but I have no data regarding, say, if I'm going to, I will give the patient a better overall survival if I treat before I detect clinically the recurrence. So this is a big issue.
Absolutely, absolutely. And I think these questions are sort of different compartments. The first compartment is the compartment of single time point right after surgery, prognostic marker, and where this can have current clinical implications is, again, that patient that you are not very sure. You're going to recommend chemotherapy based on histological high-risk features of stage 2 colon cancer, for example. And if you're opting to maybe not do chemotherapy, then knowing ctDNA status could lean you one way or another. So that's one. Number two is in assessing treatment response. So after you've had surgery, you can actually monitor treatment response. And I agree that right now, there isn't any strong evidence that you should change your treatment recommendations based on ctDNA changes. But you could argue that if you are offering somebody 6 months of FOLFOX chemotherapy and the patient is having significant neuropathy and significant side effects from treatment, and your ctDNA is negative and has been negative, then that might make the doctor and patient more comfortable with stopping treatment and not affecting the long-term quality of life. In terms of surveillance, which is the third issue, I agree. There are currently clinical trials trying to answer the question of, number one, can ctDNA recurrence increase the chances of finding oligometastatic disease that could be amenable to another curative intent treatment, and then ultimately impact overall survival? We really do not have strong evidence today to say that overall survival is absolutely improved upon. And so one of the studies that is ongoing is called the Bespoke trial, which is recruiting 1,000 patients, sort of a prospective observational study that will be compared to a control arm, and to see if we can actually increase, again, the chances of finding oligometastatic disease that is amenable to curative intent treatment. In regards to existing tumor markers, right, CEA, you know, what is interesting is clearly we have a tool. Signatera is a tool that is definitely more sensitive and definitely more specific than a CEA. But again, we don't have the data that shows that it actually improves our outcome. So in patients where you're monitoring with CEA and you have a high level and a questionable nodule that may or may not be cancer, it would be reasonable to consider doing Signatera, because if that Signatera is positive, you will basically almost always find out that that nodule is cancer, and that it should be either A, biopsied, or B, treated. And the same thing goes with, it's negative, then maybe observation surveillance could be the way to go. So, but I get it. I understand that, you know, further evidence of the outcome of this intensive surveillance with MRD is needed.
Okay, so I think that it is. So I would like to say thank you for your time. The presentation was excellent. So the test is wonderful. I'm pretty sure that in the next few years, we're going to have a lot of changes in how to manage our patients using Signatera. I truly believe in this test, and not only as a company, a diagnostic company, but the rationale is wonderful. So, and now we are going to learn to see the results of the trials and how can we manage those patients using the test. This will be the big deal. So I would like to thank everybody. So ourselves from GeneOne, we are here to attend you. So please visit our website of geneone.com.br, and feel free to send emails, to call us. I'm going to put my phone here. If anyone can send email or call, please feel free to do this, okay? We would like to close with anything, Angel?
No, thank you very much for giving me the platform to share what is truly going to be a new era of how we treat patients with solid cancers, which is very similar to what hematologists have been doing for decades now, treating leukemia. And it's you know, we obviously, hopefully we can demonstrate that we can make an impact at the end of the day, a positive impact, a good outcome for our patients.
So the last question. So do you have any data regarding Signatera for non-Hodgkin's lymphomas?
It's being generated. It's being generated. Very early data, but we do expect that it can perform very well as well. As you know, that is certainly a population of patients that could benefit better from early recurrence and potentially improve upon PET scan monitoring. And we're very anxious to, you know, to complete those studies.
Okay, thank you. See
Thank
you
you.
on the next talk. Bye.
Until next time. Bye-bye. Take care.
Thanks for everybody for participating.
Thank you.
Bye.